welcome to all of you. Hopefully, many of you will have attended a CornerStones webinar before. This is now the 13th iteration, or the 13th year, I should say, actually, of Best of DDW. But for those of you who haven't been on a webinar before, perhaps we'll just briefly explain what's involved in Best of DDW. And I think the first thing to say is it's a pretty involved process in which the faculty and fellows are selected from around the world across about 12 different countries, and then are assigned into teams to look at different areas of the data that are presented at DDW. And we basically then, in our teams, review all of the IBD abstracts at DDW, it's often up to 1,000. We then select those that are of most interest and in a fairly wide way, and then the presentations, be they oral or poster presentations, are attended to try to work out which are the ones that are of greatest interest. The team, and we'll talk about the team in more detail in a moment, creates slides of that, and then after DDW, the day after DDW, we all gather and do a sort of a 4 or 5 hour meeting in which the teams present their best of slides, and at that meeting we vote for the ones that are going to be included in the final deck. Now, in fact, James and I then try and cut that down a bit more to the ones that we think are most interesting to our audience. And as you can see, there's over 30 webinars presented around the world, which we tend to do about 3 and 12 and several face-to-face meetings, and we do those as well. Just some pictures here of the meetings, as you can see. I said I'd talk a little bit more about the teams, and this is the most important picture because these are the fellows who do most of the work, particularly putting together the slides and hounding presenters for copies of the abstract so that they can give you the most accurate set of slides for you to take away afterwards. This is the faculty here. Marla and David are the course directors, James and I from the UK, and as you can see, a large US faculty, Asia Pacific faculty, as well as an Australasian faculty. And I'd just like to highlight particularly Aaron from Barts and Sam from Guys and Tommies, who were the UK fellows this year and have done a fantastic job in helping to make this happen. It's a lot of work, and they really do a great job. So these are some of the areas that we're going to be covering. Now, we're probably actually not going to cover all of these areas, and I'm just going to do a little plug for our deep dive webinar on the 11th of August, when we'll perhaps be delving deeper into some of the areas we don't cover tonight, but we're going to give you a little potpourri spread across several of these areas, and we're going to start with James, who is going to talk about diagnosis, prognosis and prevention of IBD.
Yeah, so thanks, Pete. I've selected a couple of summary slides really to highlight some of the many epidemiology abstracts that were presented at DDW, and this is a mixture of 6 different abstracts looking at the changing incidence and prevalence of IBD across the world. Top left, we have a US abstract. This look was based upon a claims database covering a very large number of American patients, then extrapolated across the population, requiring for a diagnosis of IBD to have both IBD codes plus an appointment with a gastroenterologist, or IBD codes plus at least 2 prescriptions for an IBD medication. And they now have an estimated prevalence within the US of at least 1%, which is making about 2.3 million patients with inflammatory bowel disease across the US. Within that, there's a much more nested study, population-based, coming out of the Mayo Clinic in Minnesota, looking at changes in incidence over time. And what you can see here is comparing 2 different epochs, the noughties and the tens, looking at Crohn's and ulcerative colitis. And you can see that the previously increasing incidence of both Crohn's and UC is beginning to slow here in Olmsted County, Minnesota, with just a slight reduction in both Crohn's disease and ulcerative colitis. That's certainly not the case in this population-based study from Denmark, admittedly looking at a slightly longer time period from 1995 to 2018, so slightly wider time period, where they've seen a dramatic increase in the incidence of both Crohn's and ulcerative colitis. So certainly, although in some areas that incidence curve is beginning to plateau, in others it's not. And of course, we've got to remember that the increase in prevalence continues, obviously, even though the incidence may be the same. Coming up here on the right-hand side, a study on prevalence here, and you can see the impact of the increasing incidence on prevalence, both in Crohn's and ulcerative colitis. This is a population study from West Hungary showing that you know, almost a sort of 40–50% increase in prevalence. Top here is it's a completely different type of study. It was looking at 2 different tertiary referral centres that operated both hospital-based and community-based colonoscopy, and looking at the diagnostic yield across about 15,000 colonoscopies, showing that about 6% of those revealed inflammatory bowel disease, the majority being Crohn's compared to ulcerative colitis, and perhaps slightly against what one might have thought, there was no difference between the yield for inflammatory bowel disease between urban and rural centres. The last really just highlighting the fact that even in areas where, this is from New Zealand, even in areas where the incidence in Caucasians may be plateauing, that doesn't mean that it's plateauing in other ethnicities, and this just showing the rapid current increase in inflammatory bowel disease in the Maori population of New Zealand. I'm going to then move to the next, which again is a collection of different abstracts looking at the protective risk and protective effects associated with the development of inflammatory bowel disease. So this, in general, are sort of cohort type studies. The first there, number 1, was a cohort study looking at I think from Denmark, I'm pretty sure it's from Denmark, looking at the risk of developing inflammatory bowel disease associated with prior exposure to mebendazole. Slightly surprised me how much of the population had been exposed to mebendazole. It was strikingly high. But what you can see here is that particularly exposure to mebendazole at less than 5 years old was associated with an increased risk of adult onset ulcerative colitis, but not Crohn's disease. And mebendazole exposure greater than 5 years also was not associated with an increased risk. Here, number 3 here, the was again a Danish study looking at the impact of early life antibiotic use. Take that back, sorry. This was looking at the impact of antibiotic use in the incidence of older onset inflammatory bowel disease, i.e. diagnosis of IBD greater than the age of 60. Now, we've known for some time that childhood use of antibiotics is associated with adolescent onset inflammatory bowel disease, and this was looking to see whether antibiotic usage in the years prior to age 60 was associated with an increased risk of older onset inflammatory bowel disease. And as you can see here, there was a dose effect in that the more courses of antibiotics that you were exposed to, the higher the risk. And obviously they had a sort of a cutoff window, so antibiotic use within the 6 to 8 months prior to a diagnosis was not counted, just in case it was associated with the sort of early diagnosis. The study down on the bottom left looking at asthma and allergic rhinitis came from Manitoba in Canada, and was seeing whether there was an association with a prior diagnosis of asthma or allergic rhinitis and a subsequent diagnosis of inflammatory bowel disease. And you can see here that there was, with about a 60 and 100% increased risk in patients for Crohn's and for asthma and then allergic rhinitis. This did not, I think, correct for prior antibiotic use associated with the diagnosis of allergic rhinitis and asthma. So I think there's a slight health warning on that. The number 5 here was the US IBD nurse 2 cohort study. So that's a large, I think it's about 160,000 US nurses, so predominantly a female cohort, obviously therefore looking at older onset inflammatory bowel disease, because they were all recruited around the age of 25, so it's onset of IBD after that, showing, looking at a questionnaire that assesses emotional abuse as a child, showing that there was an increased risk of developing Crohn's disease, but not ulcerative colitis. And again, if you looked at quartiles, I think they did, or quintiles, in terms of the distress score that was used that rated emotional abuse as a child, there was a sort of dose effect. The EBV story here on the bottom came from a series of small cohorts, including the American servicemen cohort, where they American servicemen give a serum sample every year to check they've not got HIV or hepatitis. That serum sample is saved, so you have years and years worth of serum samples, and within that cohort you can identify people who subsequently develop inflammatory bowel disease, and they can show that in those that do compared to those that don't, those that do are significantly more likely to have had prior exposure to EBV, and that was shown in 2 other cohorts, including the GEM cohort. And GEM is the large Canadian European study of about 5,000 first-degree relatives of people with Crohn's disease, and those first-degree relatives might be siblings, they might be parents or children, and those 5,000 first-degree relatives have been followed over about 5 years, and around about 80 of them have subsequently developed inflammatory bowel disease. So 80 siblings who didn't have IBD at the time of recruitment have developed it, and therefore you can look to see what's different about those who do develop IBD compared to the larger majority who don't. And you've got quite careful matching, because obviously 80 versus 5,000, you can match quite carefully, and I think they do it about 2 to 1. And they showed, here we go, that living with a dog was protective against developing Crohn's disease, particularly if your exposure to the said canine was between the ages of 2 to 4. Sadly for cat lovers, living with a cat was not protective, and as has been shown many times before, living in a large family was also protective. And so I think that's probably the end of our study of epidemiology, and there is a question here
from Suze.
How are epidemiological studies corrected for increased diagnostics? Has the incidence actually increased, or are we just looking for it? Well, I think that's a really good question, because we're looking for it more, and we're finding more because we can do capsule endoscopy and therefore diagnose people who previously would have not been diagnosed. I think that is a complete confounder with epidemiology. For these kind of studies, you can't correct for the fact that the way we assess diagnostically evolves, as well as the way that we, as well as potentially the risk. So it's completely true to say that that is a confounder.
Why are dogs protective and cats not?
Yeah, it's a good question. Are we more likely to get close to our dogs than our cats?
Do you know what
are we more like dogs lick your face and cats don't?
Yeah, and that's one thing. Dogs do. Yeah, they don't tend to lick your face. Cats. Dogs don't bury their feces.
Dogs don't bury their
whereas
feces.
Cats do.
Oh, I see. So you're more likely to be exposed to doggy feces.
Right, which is probably good for you.
Which is probably good for you.
So smear. No.
There's a thought for us all. Right. I think Peter, it's you next.
Okay. The next section, which is on non-biologic small molecules, comes with a health warning. There's quite a lot in here this year, and it's in stark contrast to recent years, which I think is a good thing. we've talked about biologics an awful lot over the last 10 years, and now we're starting to see an explosion in small molecule data. We're going to start with data about the one small molecule that we've had the most experience with over the last few years, and that's tofacitinib. And of course, the big news about tofacitinib, probably inappropriately bigger than its efficacy, because it's a highly effective drug, has been its safety signal. And one of those safety signals has been the increased risk of venous thromboembolism that was seen certainly in patients with rheumatoid arthritis who had risk factors and over the age of 50 in the oral surveillance study. Hasn't really been borne out hugely, to be honest, in the ulcerative colitis cohort. And this is an attempt using large American pharma databases health insurance databases to try to understand whether there's actually a difference in risk factors for VTE between people treated with anti-TNF and tofacitinib. Whilst it was a large cohort, they actually had far fewer patients who were treated with tofacitinib, not surprisingly, rather than the patients who were treated with infliximab. So I think they compared about 300 tofacitinib treated patients with nearly 19,000 anti-TNF treated patients. Either way, of course, as James just talked about the GEM cohort, it allows for good matching, and they did propensity score matching. And of course, the most important thing they found was that thrombotic events were low in both groups. And of course, the biggest way that you can prevent thrombotic events in inflammatory bowel disease is to treat inflammatory bowel disease. And they found that tofacitinib was not higher risk than anti-TNF agents. The abstract slightly disagrees with the slide here in that the first column there on VTE, actually the anti-TNF bar was 4, not 3. Either way, there was no significant difference between them, not only for VTE, but also for major adverse cardiac events as well. Excuse me. And then the second tofacitinib study is a study from a group of collaborators in France who were trying to understand a little bit more about tofacitinib and comparing it to vedolizumab. So again, a propensity score matched analysis of patients, which is incredibly important, obviously, when you're comparing drugs that are as different as tofacitinib and vedolizumab, and they aim to see how able these drugs were to induce corticosteroid-free clinical remission, endoscopic improvement, and mucosal healing at week 16. Slightly more evenly matched cohorts this time, about 180 vedo-treated patients, 126 tofacitinib-treated patients. And you can see if you just look at corticosteroid-free remission at week 16, pretty similar, 55% in the tofa group, 43% in the vedolizumab group. But if you then start subdividing these patients to try and understand a little bit more about them, if you look at those patients who had had at least 3 biologics before, you see that tofacitinib really didn't sort of lose any of its ability to induce remission, if you like. So 57% of these patients achieved corticosteroid-free remission at week 16, whereas only 6% of the vedolizumab-treated patients were effective in this cohort. And then the other thing that really mattered is if you'd failed a biologic before, and all these patients had failed at least one biologic, if you had primary failure, then tofacitinib again came out as more effective than vedolizumab. And to me, that rings true. Tofacitinib is a drug that works well in patients with difficult disease. Vedolizumab is a drug that perhaps works less well in that cohort.
And we're certainly seeing signals from the other JAK inhibitors that the drop-off in delta that you see when bio-exposed patients doesn't seem to be as marked with some of the JAK inhibitors as it is with other biologics.
And I think not only do we see that in other clinical trials, but we see it in clinical practice, don't we? You know, this is how the drugs behave. And speaking of other small molecules,
I think it's me next. Yeah. So this is one of a couple of abstracts we've got on upadacitinib. That is a JAK inhibitor that is selective towards JAK1. and this is data from the two induction studies, which took people with moderate to severely active ulcerative colitis and randomized them to the single dose UPA 45 milligram once a day versus placebo. And what this abstract is looking at those sort of nearly 1,000 patients across those two trials treated with upadacitinib and comparing the speed of onset in terms of patient-reported outcomes compared to placebo. And if you look at the graphs, the variety of different, I think, very relevant patient-reported outcomes, stool frequency less than or equal to 1, which is therefore 2 or more stools than normal, stool frequency equal to 0, which is therefore the normal number of stools, rectal bleeding subscore of 0, which is no rectal bleeding, pain, or bowel urgency. What you can see is that you begin to get separation, significant separation between the drug and placebo as early as day 1 and certainly by day 2 or 3, suggesting that certainly in some patients, upadacitinib works remarkably quickly. And I think that's, from a patient perspective, is very meaningful data.
Rectal bleeding disappearing quickly is a very good sign of inflammation getting better.
Absolutely. I think, I mean, you know, there are different markers of activity, but I think rectal bleeding and urgency, that they're markers of rectal disease.
Yeah.
And that's historically been one of the most challenging areas to treat. You know, in a lot of clinical trials, you can see that some of the proximal disease gets much, much better, but you still get left with a rectal ulceration. So I think this is very strong data. This again is looking at those same suite of studies, the phase 3 studies for upadacitinib in ulcerative colitis, both the induction, and I've highlighted those before, but also the maintenance, looking at the impact of the drug on extraintestinal manifestations that were present at baseline. Just to highlight, the maintenance trial of this study was randomized responders. So you had the induction study. At the end of the 8-week induction study, if you were a responder, you could enter the maintenance study. And in the maintenance study, you were re-randomized to one of 2 doses of upadacitinib, 15 or 30, or placebo. And so on the top here, we've got the induction studies where you can see that with drug in red compared to placebo in blue, there was a numerical but not statistically significant benefit in terms of reduction of symptoms of extraintestinal manifestations. Or is on the left, arthropathy and then anemia. Important, sorry, I should have mentioned that there were about 80 patients in placebo and 165 in the UPA group in induction. And then in the maintenance, as one might expect, because this was then randomized responders, the cut is even, about 30 or 40 patients in each. What you see that I think is a really interesting clinical message is that when you look at the end of the maintenance trial, you can see a much clearer benefit of drug and also, importantly, a very strong dose-dependent benefit, so that it's the patients who receive 30 milligrams of upadacitinib in the maintenance arm that seem to do the best in terms of resolution of extraintestinal manifestations. And that might be one marker by which we can decide in clinical practice which patients at the end of induction should be going on to the 30 versus the 15 milligram. You know, we sort of have a thought that the patients who are previous bio-refractory patients might require a higher dose, and also patients who have an extraintestinal manifestation or anemia at baseline might be another group of people who deserve merit the 30 milligram dose.
So one of the things I'm slightly interested in here is patients with angst-spond.
Yeah.
You know, because angst-spond is not that uncommon in combination with IBD. Anti-TNF obviously works, but we're a bit limited beyond that, aren't we? And there's a bit of a signal that JAK inhibition might work.
Yeah, and I don't know, has there been a trial of JAK inhibition?
Yeah, they're ongoing. Yeah,
it's ongoing, so it's not, we don't know the results yet.
I think there might be phase 2 out.
Right.
Yeah, no, I think there's some very positive signals, but I'd have to look up, but definitely ongoing trials.
And now, I've said this at previous meetings, but I think this was my favorite abstract at DDW. This is the phase 3 data for upadacitinib, so still this JAK1 selective small molecule in Crohn's disease. So this was the induction data in Crohn's disease. And there are two very important facts to consider about the design of this trial. It took a standard cohort of patients with moderate to severely active Crohn's disease. It required endoscopic evidence of disease activity as well as a clinical burden of symptoms. Importantly, unlike pretty much every other induction trial, which keeps people on the same dose of steroids throughout the induction period, and then they begin to wean when they are on maintenance, this had a mandatory taper of steroids at week 4. So, I mean, admittedly, I think it was about 35% of patients were on steroids at baseline, but those that were had to reduce their steroids from week 4. And so when you get to week 12, they will have withdrawn from steroids. And that's different from the majority of induction trials that you see. And then the other thing I think of notice is this was a very refractory patient group. I think upwards of 90% had been exposed to anti-TNF. And you can see here 2/3 of patients had failed at least 2 different biologics. And so this was a refractory cohort of patients with an enforced steroid taper, looking at a primary endpoint of remission at week 12. This is looking at the EU definition of remission, which used patient-reported outcomes, and you can see a strong signal of benefit, 40% of patients achieving remission at week 12, significantly better than placebo. And then the co-primary endpoint was endoscopic response, which I think was a fall of 50%. I think it was a fall of 50% in the SCSCD. And again, you can see a strong signal of benefit. And then in terms of speed of onset, we get this looking at the Crohn's disease activity index, and you can see that you begin to see a signal of benefit as early as week 2 after treating. We haven't got the granularity of those day 2, day 3, day 4 data that I showed with ulcerative colitis. But I think this is really exciting, really strong data supporting the use of JAK inhibitors in Crohn's disease. And this is, I think, the first phase 3 trial of a JAK inhibitor in Crohn's disease.
When do we get, or when is UPA going to be licensed in UC, and when is it going to be licensed in Crohn's disease?
It's a good question. You see very soon. You see it here very soon.
Very in Europe.
In Europe, it is already in America.
Yeah.
And in Crohn's disease, I think we're talking about the end of the year.
Yeah. Yeah. Very exciting. But of course, there is another JAK1 selective drug, which is actually already licensed in the UK in UC and nice approved. Nice approved. So let's talk a little bit about filgotinib, just to remind us that it's out there. So a couple of, we've partly included these abstracts to remind us that new drugs are available to us now. This is sub-analysis of the selection study, which was the sort of registration phase 3 studies looking at filgotinib in patients with ulcerative colitis. I'm not going to spend too much time on this because it's a sub-analysis, but I think the important message here is that if you look at the patients across the different age groups, filgotinib was equally effective throughout all of them. So what they did is they took the patients in the different age groups and looked at the efficacy of filgotinib compared with placebo. So if you look at the bar chart on the right there, filgotinib in orange, placebo in blue, and you can see they split these cohorts up into 30, 30 to 40, 40 to 50, 50 to 60, and greater than 60 to 75. One of the things that slightly surprising me actually here is how many patients there are actually in that over 60 group, because we kind of often think that we don't recruit those patients particularly well to clinical trials, but that seems not to be the case here. I think the important message here is the drug works across all age groups. That doesn't necessarily say anything about side effects, and of course side effect profile is really important, and one would expect side effect profile to be worse in older patients, and indeed there was a bit of a signal of that. So the patients in that older age group of 60 to 75 years did have an increased risk of adverse events. But I think you see that pretty much in most of the drugs that we use in inflammatory bowel disease. And then there's a second filgotinib abstract that I want to show you. This actually does go back to trial design. James has just told you about a trial in which patients were re-randomized according to response, and indeed that happened in the filgotinib studies. But the filgotinib studies were a little bit different, and they started off with 2 different induction doses, 100 and 200. If you responded to those induction doses, then you were re-randomized either to stay on the same induction dose or go to placebo, as opposed to being re-randomized to potentially a different dose. So you get the 200s, and they kind of run parallel to the 100s. Now, inevitably, when patients respond to drug and then in the maintenance arm are re-randomized to placebo, many of them relapse. And as with most studies, not quite all, but as with most studies, those patients who relapse then go into open label treatment. And in that open label treatment, they restarted the same dose that they were on in induction, to which they responded. The reason I'm going into this in slightly tedious detail is because you will probably remember from the original studies that the 200 group actually did better than the 100 group. But interestingly, if you were a patient who responded to 100 and then lost response when you went back onto placebo, then you actually did just as well when you restarted that 100 as the 200 patients who responded. So it's almost like if you found your dose and then you respond to it, then all you need to do is go back on that dose. It's not like you need a bigger dose to recapture response. And indeed, once you did restart drug, then the majority of patients did pretty well there. So if you look in the open label extension by week 12, more than 75% of patients had responded by then, and more than 40% of them were in remission. Let's remember here, I think it's always important to remember when you're looking at studies like this that agency FDA, EMA defined response and remission is probably quite different to what we define as response and remission. These patients that we think respond wouldn't necessarily hit the bar for response or remission in terms of a registration study. The other drug that is just worth remembering is available, at least is licensed at the moment, is Trasomod, currently going through NICE assessment, I think. This is, of course, an S1P receptor modulator, which is licensed in the treatment of ulcerative colitis. It's also been used for multiple sclerosis in the US, but I think hasn't been available in Europe, or at least not in the UK. So this is actually some real world data coming from Chicago. You can see it looks at 30 patients, 27 of whom had ulcerative colitis. 2/3 of them had previously been exposed to biologic, and they had moderate disease activity in SCCAI of somewhere between 5 or 6. I think real world data are useful. They give us a feel for how the drug works in clinical practice. And of course, almost none of us have any real world experience of this as yet. A few of us took part in the clinical trials, but it's nice to see it out there in clinical practice. You can see that by week 26, about somewhere between 25 and 30% of them were in steroid-free remission, although they certainly had some non-responders as well. They did a slightly suspect analysis looking at the patients who'd responded to vedolizumab. The logic here, of course, is that vedolizumab is an anti-trafficking drug, and the way that the mechanism of action of Trasomod is explained is kind of related to trafficking as well. I guess, to put it simplistically, it's about trapping lymphocytes in the lymph nodes. But I really, and therefore what they're trying to say here is the fact there was no difference between patients who had been treated with vedolizumab and those who hadn't suggests you shouldn't discount a second trafficking mechanism of action. I think this is tenuous, to say the least.
Yeah, I mean, I think the only thing you can say about the data is that there is some real world data now. Drug is being used in the US, and the background, it seems to support the data from the phase 3 clinical trials.
Right, and there's a little bit more Trasomod data. This is very similar to the abstract that I've just presented to you with filgotinib. It's about recapturing response after the drug has been withdrawn and therapy has been reinitiated. So it's exactly the same. Remember, it's a group of patients who've responded to initial therapy. They've then been re-randomized to placebo in the maintenance part of the study. They've lost response when they've been re-randomized to placebo, and then they have restarted drug. And what you can see here is that those patients who restart therapy after loss of response seem to do pretty well when they restart drug. There's also a little bit of evidence that there's a feeling that there's a bit of a hangover here in terms of the time it takes to flare after you've withdrawn drugs. So you can see, if you look on the left-hand side, the mean time to flare in the placebo-treated patients was actually about 2 months, which is quite a long time. Remember that ozanimod has an active metabolite as well. In fact, I think that its mechanism of action is largely felt to be through that active
which
metabolite,
has a much longer half-life.
and it has a longer half-life there as well. And then I think the final ozanimod abstracts we're going to show you are these two here. One is about extended induction, and again, this is a trial design thing. We've seen this before with several drugs in the past in trial design. As you will remember, in induction studies, you will get drug or placebo. If you don't respond to drug, many of the studies nowadays allow you to go onto a second course, if you like, of the induction period of the drug. And of course, that then allows you to understand what proportion of those patients who didn't respond in the first induction period did respond with extended induction. And you can see here, if you look at the left-hand side of the graph, that a second 10-week course of ozanimod captures about another 45 to 50% of the patients who didn't officially respond in that first 10 weeks. I think it's important to point out that doesn't mean that they got absolutely no response at all. It means they just didn't quite hit that definition of response. I think the other thing that's interesting here, when you're thinking about how long you go on treating a patient for who is, in inverted commas, not responding, is that the vast majority of them going into that second 10-week period, if they're going to recapture, they recapture after just 5 weeks. Look at that graph at the bottom left-hand corner there. After 5 weeks, 44% of the people who are going to respond have responded, and it only goes up to 49% at week 10. So it kind of says, if you're going to give that extended induction, 5 weeks is probably where you should give it for. The right-hand side of the slide looks at open label extension patients who've responded and go on and get open label treatment. I think, to summarize this, what this tells us is out to 1 and 2 years, what we're seeing is that drug seems to work over time. There doesn't seem to be a long-term loss of response any more than you see with any of the other drugs.
So I think it's me next, and I'm going to be talking about one of the other sphingosine 1 phosphate receptor. This is a Trasomod. It's got a slightly broader action than ozanimod, so it modulates the 1, 4, and 5 sphingosine 1 phosphate receptors, whereas ozanimod is 1 and 5 alone. And the first slide is just to highlight a couple of things about the trial design. There were 2 trials here. The first is a treat through induction and maintenance trial. And so this took people with active disease at baseline, randomized them 2-to-1 to either drug at a flat dose or placebo, and then followed them up throughout the 40 weeks of the trial. They did an assessment at week 12, which they called the induction endpoint, and an assessment at week 52, which was the maintenance endpoint. So this is a treat-through trial design, and that has 2 consequences when we look at the results. The first is, of course, that this is all comers. This is the end of the maintenance arm includes an analysis of everyone who entered the induction arm. Unlike the majority majority of phase 3 trials where the maintenance arm only includes patients who responded to induction dosing. So to some extent, this is a more rigorous definition. There is another consequence of that kind of treat-through design, which is that you do allow the sort of slow responders to maintain themselves in the trial. So if you hadn't quite responded at week 12, you would have been excluded from a traditional phase 3 trial in the maintenance arm, but this you could continue. So you could sort of slowly drift into response over the 40 weeks. So that's the Elevate 52, a treat through induction and maintenance trial. And the second is the second induction trial mandated by the FDA to have 2 induction trials, or certainly a large number of people in induction trials. And importantly, this started recruiting patients well after the initiation of the treat through induction maintenance trial, and that has relevance. So if we look first of all on the right hand side here, this is the treat through induction and maintenance. You can see primary endpoint remission, patients with ulcerative colitis, as I mentioned, and you've got a really nice signal of benefit over placebo, a large delta of almost 20%, with upwards of about a third of patients at week 12, and again, a third of patients at week 52 being in remission compared to placebo. And at the bottom here, you can see a variety of different secondary endpoints, including endoscopic improvement, symptomatic remission, and mucosal healing, which was a composite of histological and endoscopic endpoints. Again, across all of them, a nice strong signal of benefit. Then we come to the second induction study, and again, this does show benefit, but as you can see here, looking at the primary endpoint, the delta is much lower because the placebo rate is much higher. And I think that reflects the fact that at the point that this trial, that this second induction trial was recruiting patients, the investigators had a feeling that the drug worked because they'd already been doing the induction maintenance trial, and they will have known where the patients were getting better. So I suspect that high placebo is a downstream effect of the investigators having confidence in the trial, because the endpoints were exactly the same.
So it's fascinating, isn't it? What's equally fascinating is that low placebo response at week 12 in Elevate UC 52 clinically. I mean, that is a low placebo response, particularly at week 12. You know, often as you push the time point out, you get more of a placebo response. So
fair to say, of course, therefore, this is a longer, and you highlight, good point to highlight, this is a longer induction period than we've seen in many of the other UC studies, which have been either 8 or 10 weeks.
Or 6.
Originally for Infliximab and
Vedo. Yeah, interesting. Should we do the questions and come back to this one?
Okay, well, let's see.
Because I think there are a few questions. And this isn't small molecules, is it?
Oh, yeah, there are some questions. Hang on a sec. Okay, so a question from Anjan. What's the current state of the hygiene hypothesis? Well, I think it's still very much there. The concept that exposure to microbial, be it bacterial or fungal or parasitic, early in life is protective against inflammatory bowel disease. I still think that holds.
Next question, also from Anjan, is the risk of VTE on MACE due to tofacitinib and other JAK inhibitors higher in the over 65 years patients with UC? So I think the answer to that is probably yes. We don't really have specific data on that, but what I would say is, if you look at the tofacitinib trial program, where you see venous thromboembolism, it's only in the open label extension. It's not in the induction and maintenance studies. It's in the open label extension. It's only in the 10BD group, and it's only in patients in whom we see risk factors. And I think increasing age is a risk factor. You know, I don't think one can definitively answer that question, but I would be more cautious about use in those patients, not just for the VT risk, but for other risks as well.
Yeah, and then a great question from Lavashtal here about can you see JAK inhibitors upadacitinib or Topher being used in acute severe ulcerative colitis? And obviously the simple answer to that question is currently there is very limited data from controlled trials, and they are not truly licensed for that. But the slightly more complicated answer is there is now an increasing number of papers, the largest coming from Michigan, looking at high-dose tofacitinib as a treatment for acute severe ulcerative colitis in patients who, for whatever reason, couldn't receive infliximab. And it used 10 milligram TDS, so that's higher than the normal dose we use, and it showed really quite striking benefit. And certainly we've used 10 milligram TDS Topher in a patient who has previously failed infliximab with acute severe ulcerative colitis with success. I think it'd be fair to say that you need to get that dose down as quickly as you can, because the risk, particularly, well, we know from the risk of all the JAK inhibitors is dose dependent. Final question. I don't know. Oh, sorry.
I was just going to say we've used tofacitinib on a fair few acute severes who have not quite properly responded to infliximab, partial responders, and then rapid loss of response, or you're having to give infliximab all the time.
And you put
and then we changed them over to Topher in hospital.
It's a
and
slightly
captured them.
different population, because they are no longer acute severe. They have partially responded.
Right, exactly right.
But it is also they're leaching infliximab. This is a great question that I'm sort of going to hesitate on the answer.
Thanks, Steve.
Sue's asking, is Topher safe to use in a patient with ITP? I think it's really difficult. So Topher obviously has broader JAK activity, or broader impact on the range of JAK inhibitors, and certainly JAK2 is very involved in hematopoiesis. UPA, on the other hand, more JAK selective, less likely to cause hematological side effects. That would certainly be a question. And I know, of course, that some of the hematological conditions are predisposed in people with mutations of the JAK pathway.
Right.
So I think that would definitely be a question I would ask my hematology colleagues. I'm not sure I know the answer.
I think I would definitely talk to a hematologist. We don't see thrombocytopenia terribly much, do we?
No, we don't. So it should be good.
And I would hope it would be fine. I wouldn't be hugely worried about it, but I'd probably ask a friend. And then this final abstract in this section. Section. Thank you, James. Is not about small molecules. It's about enteral nutrition. And enteral nutrition is something that's probably closer to our hearts in the UK than it is in many parts of the world. And I think many people use this practice already, although I also know that in the United Kingdom, many people don't. So this is a study that we put together at Guy's and Tommy's, and I should just say that Suze Mead and Kamal Patel did a lot of work on this. And it looked at patients who were undergoing resections for Crohn's disease, and it compared a largely historical cohort of patients who didn't have preoperative enteral nutrition with those who did have preoperative enteral nutrition. What do we mean by that? Well, we aim to give 6 weeks of exclusive enteral nutrition. Normally we use Modulin, although our dietitians, who are fantastic at supporting these patients through this process, will also use other nutritional supplements if needed, and indeed if it wasn't possible to get them all the way through on enteral nutrition, they would often allow a partial enteral diet, but nevertheless aim for 6 weeks of preoperative enteral nutrition prior to surgery. In conjunction with that, of course, it allows drainage of sepsis, use of antibiotics in patients who have sepsis, and withdrawal of steroids. So there are multiple benefits to this, and the ultimate outcome that we looked at here was post-operative complications, and it was clear in a non-randomized cohort of patients, it was clear that there was benefit to using enteral nutrition. Now, of course, I think one feels a little bit more confident about saying about stating the benefits of preoperative enteral nutrition, when you think that this is not the only study to show this. There are several, one indeed from Exeter a few years ago, published in APT, as this study has recently been as well. But this is now absolutely standard practice in our centre. James, I think you do a reasonable amount of this now as well. One little extra point here, there is an RCT that's been funded by NIHR, which is being run by Rachel Cooney in Birmingham. So if you get the chance to recruit to that study, please do. It needs a lot of support, and it would be wonderful to have an RCT that actually supported this practice. In the meantime, personally, I think the open data are strong enough to make this standard of care for us.
Yeah, definitely. I think
it's back to you, James.
No, it's not actually.
It's me.
We're going
it is, because we are going
abstract.
to my favourite abstract. And unlike James, who chose a pharma study, I chose an investigator-initiated study. So this is from Edouard Louis, who many of you will remember did the STORY study many years ago. So that was a study that looked at patients with Crohn's disease who've been on a combination of infliximab and azathioprine for at least 6 months. And they withdrew the infliximab to see what happened to them. And you may well remember that over the 2 years, about 50% of them responded. Interestingly, when you restarted the infliximab, many of them recaptured response. And in an open label, in sort of a late follow-up of that, where they followed out to about 7 years, I think, the vast majority of them actually lost response over time. But of course, there was no control arm. And so this was the study that Edouard designed to try to address the lack of control in that study. So this is a big European funded study, and it randomized a similar cohort of patients to withdrawal of infliximab, withdrawal of azathioprine, or continuation of both drugs, and followed them up for 2 years. And the primary outcome here was relapse over time. And what you can see is, and this won't surprise many of you, that if you stopped the infliximab, then you were far more likely to relapse than if you continued infliximab. Interestingly, it didn't actually matter whether you continued infliximab with azathioprine or whether you stopped the azathioprine. Now, I said that's the primary outcome, but of course, there was another primary outcome as well, as you can see, and that was the sort of mean amount of time that you spent in remission over the 2 years. And the reason that's important was because if you did relapse, you were then allowed to restart drug. And if you restarted drug, then the answer is you tend to recapture response. So instead of looking at these survival curves in figure 1, which is that first endpoint I described, look at the pie charts here in figure 2. And that's the mean amount of time that you spent in remission over the time of the study in each of the different arms. And what that shows you is it doesn't actually matter which strategy you follow, as long as you restart the drug, then you recapture response. There may be caveats to that, and I'm going to let James raise one of those in a moment. Just before you do, though, I'm going to put my own caveat in, because I think there's a danger of misinterpreting this study. Okay. And that danger relates to the old practice that people have followed from the IMID study, the Hans study from many years ago, in which people withdrew azathioprine when they were on combination therapy after 6 months. And a lot of people follow that practice. And it would be possible to look at these data and say, well, this supports that practice. You can stop the azathioprine and you do just as well as if you carry it on. But I would point out to you that that's actually not the same cohort of patients as we see here in SPARE. These are actually patients who've been on combo therapy for a long time on average. I think about, they don't actually tell you enough, about 5, 6, 7 years. And therefore, you've probably actually pre-selected out the antibody forming patients because they're more likely to have lost response by the time they get here. And so you're probably selecting a group of patients here who are less likely to benefit from azathioprine.
Yeah, absolutely. And my comment was more about personal experience, which was that in my personal experience, when I stopped infliximab, I agree, 50% of patients flare over time. But I don't recapture as many patients as would be suggested from this. And I don't know whether that's because these patients were in a deeper remission, or whether they were on whether they were, as you say, selected for non-antibody forming type patients. But we do still see a significant minority of patients who, when you restart the infliximab, having had a flare, they have one infusion, and their second infusion, they develop an infusion reaction and don't stop. So I would be surprised if we captured 90-odd% like they have.
Yeah. There's another possibility, isn't there? And that is, this is a clinical trial. And so you're having an absolutely sharp eye kept on you, and you're looking for that loss of response. And the minute you get that loss of response, the chance of you restarting is high. In real life, you know, you can potter along for a while, and I think you're right. I think you're more likely to run into trouble there.
So I'm going to do a couple of sub-Q type studies, and these are two studies looking, this first one at infliximab and the second one at vedolizumab, about the practice of switching from IV to sub-Q therapy. Phil Smith from Liverpool has published a UK cohort of infliximab IV to sub-Q switching, and that's now out in the literature. That was presented. It was a great trial. I'm showing you this one because it just addresses a slightly different point. So this was a cohort of patients who were in stable remission on maintenance intravenous infliximab, and they were then switched to subcutaneous. At the point that they were switched, they could have been on one of a whole range of different IV doses, including standard, sort of escalated dose, and then two doses we might find hard to use in the UK, 10 mg every 6 weeks and 10 mg per kg every 4 weeks. So some patients on really quite high doses before they were switched. They were all switched to standard dose 120 milligram every other week sub-Q. So they were all switched the standard dose, although if they then flared, they could escalate to double dose sub-Q. And what you can see across a variety of different time points is that the patients were quite well assessed, and you can see definition of relapse, whether it was UC or Crohn's disease, based upon patient-reported outcomes and an elevation in Calpro. And then if we look at the results, about 130 patients, the majority Crohn's, been on infliximab for a good time, 5 years. So this is a cohort of being stable on infliximab for a chunk of time. The majority were on what we would call standard UK dosing, 70%, but therefore 30-odd%, or just under 30%, were on those very high doses. A quarter were on concomitant immune modulation. And now what you see here is the rate of relapse by infliximab dosing, the different time points, visit 1, 2, and 3, which were at 8, 16, or 24 weeks. And what you can see is that irrespective of the dose, if you were on what I would call standard UK doses, you were fine to switch to standard dose, 120 milligram every other week sub-Q dosing. A slightly higher risk of flare on that standard dose if you were receiving 10 milligram per kilogram 6 weekly, but it was the patients who required 10 milligram per kilogram 4 weekly IV who had a much higher risk of flare when they switched to standard 120 every other week sub-Q dosing. I think that's a really interesting message that suggests that we can be switching our 10 mg per kg IV patients onto 120 milligram every other week sub-Q.
I think it's a fantastically useful little bit of clinical data. In fact, 2 hours ago in clinic, I had this very question from a chap who's off to university. We just escalated him to 10.
And he can switch to 120 every other week, according to this. And the second is some vedolizumab data. I mean, it's pretty much the same. It's a slightly different study design. There were 2 cohorts from the Netherlands, one open label and real life, and the second based upon a registry looking at switching IV to subcutaneous vedolizumab. They had either UC or Crohn's disease. They'd been on at least 4 months of treatment, and they had a chunk of follow-up, not quite as long follow-up. And what we can see, if you look at the table at the bottom here at baseline, week 12 and week 24. If we look at clinical markers, biochemical markers, either CRP or Calpro, or Vedo concentration, well, we'll focus on those first, there really isn't a drop-off in efficacy with the switch to sub-Q. Interestingly, and you see exactly the same with Infliximab, when you switch to sub-Q, you get a much higher dose, drug level. And the reason you get a higher drug level, of course, is you're not measuring a trough, you're measuring a steady state. Important, therefore, when interpreting drug levels on patients who switch from IV to sub-Q, not to assume that the traditional IV trough drug therapeutic windows are the same. They absolutely will not be. And here you can see the few patients that had to discontinue, around about 10%, and the reasons for their discontinuation. Some, they didn't like needles, about a third of those who discontinued because they had a loss of response, others because of adverse events.
We've had one or two who we've swapped back because they seem to.
Yeah, I mean, and some people don't like injecting themselves.
Yeah, no, that's true. That's true. Good. So another vedolizumab study here. It's a little bit complicated, this one. I'll try to go through it reasonably swiftly. So this is a study that really looks at whether increasing doses of vedolizumab in patients with ulcerative colitis in that early phase will recapture more patients. You'll remember that in Crohn's disease, partly due to the way the trials were designed, you're allowed to give a 10-week dose, 0 to 6, and you can give that 10-week dose as well. But that's not really part of the management of UC. So this is a study that looked to see if you were responding or not responding at week 6. If you gave more vedolizumab, how did you do at that point? So it took a cohort of patients who all received standard induction doses of 0 and 300 milligrams at week 0 and 2, and then at week 6 they decided if they'd responded or not. Now, if they had responded, then they just carried on. But if they hadn't responded, then they did a drug level. If their drug level was good, they then carried on. If their drug level was less than 50 micrograms per mil, then they were randomized. And they're randomized either to carry on at standard dosing or to dose optimization. And in that dose optimization arm, they were then divided into two groups of patients, those who had a level of less than 30 and those who had a level of between 30 and 50. And then they were given different doses depending on that. But you can see, if you look down at the bottom of this little schematic on the left-hand side here, that they were giving pretty chunky doses, 600 milligrams at week 6, and then 300 milligrams 4 weekly thereafter, or in the less than 30 micrograms per litre group, 600 milligrams at week 6, and then 600 milligrams every 4 weeks. That's quadruple dosing of vedolizumab. The long and short of it is, it doesn't make any difference. The drug doesn't do any better if you give massive doses on it, massive doses of it. As James said the other week, you could hear CCGs around the country breathing a sigh of relief at the results of that. Where they may not have breathed a sigh of relief is where they saw the results of the Earnest trial. This was presented actually at UEDW, but we're going to show it again because it was presented at DDW, and I think it's a really good study. It's a really important study. It's a really good study because we don't see many studies in this group of patients, and that group of patients is patients with pouches who have chronic antibiotic refractory pouchitis, and this undoubtedly has been a challenge for us over the years, and we've started to move into the spectrum of using biologics in these patients. So this was a study, a randomized control study of using vedolizumab in this group of patients. You can see that the primary endpoint was week 14, and it was using a modified pouch disease activity index. There were also secondary endpoints of the same at week 34, plus response rates and a standard pouch disease activity index remission rate. The long and short of it is, vedolizumab is better than placebo across all of these endpoints. Remember that the pouch disease activity index isn't just a clinical activity score, it is a it's an endoscopic score as well.
And it's got histology in it too. So, I mean, I do think this is a nice result. This is the first positive randomized controlled trial in pouchitis since the original antibiotic trials maybe 10 or 15 years ago. So I think this is really nice. And we don't have anywhere near as strong data for any of the other advanced therapies. Not saying infliximab doesn't work in some patients,
no,
but this is good, strong data.
But kind of funny we don't have those data, isn't it?
Yeah, I mean, yeah, it's a niche population. Obviously, it may not justify the investment from a sort of commercial perspective, but from a patient perspective, these are a very, very group of patients who have a very marked deterioration in their quality of life because of urgency, frequency, and the risk of incontinence. So I think they're a very important population.
Very good to see.
So I'm going to this is a very brief review of another trial in pouchitis, completely different in terms of the fact that this is open label and very small, but it just effectively is showing that the Crohn's disease exclusion diet, which is 50% of your calories from enteral nutrition and 50% of your calories from a very minimal list of foods, which are predominantly chicken and eggs, is an effective treatment in this open label study in pouchitis. Now, we've seen data for the Crohn's disease exclusion diet in pediatric Crohn's and in adult Crohn's from randomized controlled trials, and this is patients with pouchitis. I don't think this is in anywhere near as strong as the previous study, but I guess it does just tell us that there is a dietary option for patients with chronic active pouchitis. Back to you.
Sure. So another couple of biologic studies. I think this is an interesting study. It's about ustekinumab and it's about fistula response with ustekinumab. Again, it goes back to the original Unity data, that was the registration trials of ustekinumab in Crohn's disease, and we saw some sub-analysis from there looking at the patients who entered Unity with fistulae, and there was a suggestion of response. So this is looking at another couple of studies using ustekinumab, both in a treat-through manner, Seaview and Stardust, and looking at fistula response in these patients. Seaview, you will know, published recently in Lancet, is a randomized controlled trial of patients with Crohn's disease treated with either adalimumab or ustekinumab, and Stardust was more of a treat-to-target study in patients with Crohn's disease. Again, just using ustekinumab, but using different strategies. Let's look at Stardust first. If you go down to the bottom of the screen, look at the blue wheel on the right-hand side there. This is the proportion of patients with fistulas who had complete fistula resolution at week 48. That's closure of all fistulas. And you can see the blue part of the circle is the proportion of patients who closed their fistulas. It's about half of them. And half of them didn't. If you then go over to Seaview, look at the blue circle again, that's the proportion of patients in Seaview who entered with fistulae who closed their fistulae completely at a year. And again, it's about half of patients. So across 3 different studies there, we're seeing pretty similar responses, all of them admittedly with a small proportion of patients entering, and you certainly wouldn't call it the worst fistulizing disease in the world because they wouldn't have got into the study if they did have it. But a signal there that perhaps anti-P40 is useful. And of course, the advantage of Seaview is it had a control arm. That control arm was anti-TNF, and we know anti-TNF is a good mechanism of action when it comes to treating fistulae. And you can see in the orange wheel at the bottom left-hand side there, that's the proportion of patients who were treated with adalimumab in Seaview who closed all their fistulas at a year. And you can see it's a little bit less than the ustekinumab treated patients. Now, small numbers, I'm definitely not suggesting that ustekinumab is a better mechanism of action than adalimumab. We need RCTs to understand fully what ustekinumab does to fistulae. There's a good one being conducted by JetAid, which will probably read out in slightly over a year's time. But I guess what this tells me is if I've used anti-TNF or if I can't give a patient anti-TNF and I need to choose an MOA that I want to have a chance of helping fistulizing disease, I'd probably go for ustekinumab. Mirikizumab is, of course, an anti-P19 antibody, and the reason we're talking about this is the first anti-P19 antibody that we expect to be licensed for ulcerative colitis, and that's based on the Lucent studies. This is the first of the Lucent studies. It's the Induction study. Now, I'm just not going to go into this in great detail because A, we're running short of time, and B, it's actually been presented before at ECHO, but I am just going to point out to you that if you look at this large induction study, well over 1,000 patients here, randomized about 4 to 1 there, you can see that mirikizumab is superior to placebo in inducing remission at week 12. Another week 12 study you'll see in both biologic naive and biologic failed patients. That's the right hand side of the graph here. So P19, mirikizumab that is an effective induction agent in ulcerative colitis. I'm not going to go into the safety profile. I think in general we can say P19 has an attractive safety profile overall. And then the novel data that were presented to DDW about mirikizumab were the maintenance data from the same study, from the Lucent program. It was one of those trial designs you're familiar with, that is re-randomization of responders. So at week 12, then re-randomized 2 to 1 to continue mirikizumab or to go on to placebo. And again, going over to the right-hand side here, you can see that clinical remission was more common in the patients who were treated with mirikizumab than placebo, and indeed maintenance of clinical remission, endoscopic remission, and histoendoscopic remission were also, that's kind of mucosal healing in the new sense of the word, were all more likely to be achieved with mirikizumab than with placebo. I think it's great we're going to have another mechanism of action in ulcerative colitis, and all things going as planned, we would expect this to be available in the not too distant future.
So I'm just going to be talking about another of the P19s. This is the Janssen P19, guselkumab, and this is data in ulcerative colitis. So this is the phase 2b study looking at 2 different doses of guselkumab versus placebo in patients with active ulcerative colitis. And what we can see across effectively the initial induction endpoint, which response rather than remission, we're now more used to seeing remission at week 12. So this is response at week 12. And here you see the remission at week 12 as a secondary endpoint. You can see, again, a clear signal, again, over and above placebo. But we would sort of expect that given the previous data that Pete's shown. And as we go across in terms of endoscopic and histoendoscopic mucosal improvement, you can again see benefit over and above placebo. The guselkumab Crohn's data, we now have the maintenance data from this. So this is a treat-through design, randomized control trial of guselkumab P19 versus placebo. We've seen the induction data previously, which show benefit of guselkumab over placebo, but similarity, not powered to show significance, but similarity with ustekinumab and guselkumab. And this is the end of the treat through in terms of maintenance. And you can see I've highlighted it in red here. The primary endpoint was clinical remission at week 48. And you can see that the 3 different induction doses went on to 2 different maintenance doses, but that there was a relatively flat remission rate. There didn't seem to be much of a dose response from the guselkumab perspective. And although one of the arms was perhaps numerically more attractive than ustekinumab, others weren't. And so perhaps you could say a very similar outcome. So we've not really seen such a strong signal that the P19s are more effective than the P40s in inflammatory bowel disease. To be fair, though, this isn't powered to show that. This is just a comparator arm. And obviously, we need to wait for the results of the sequence trial, which is the AbbVie head-to-head risankizumab versus ustekinumab in Crohn's disease trial. The final abstract that I'm going to present in this section I think, is one of the first of the combo trials. Now, this I think is really interesting. This is the use of combined biologics in patients with refractory disease. And so this is looking in patients with moderate to severe ulcerative colitis, and they're randomized to either an anti-TNF golimumab or an anti-P19 guselkumab, or combination of both drugs together. And what you can see at the end of induction, which is week 12, the primary endpoint remission, you can see that the primary endpoint response, my apologies, you can see that the combo does better than the P19, seems to do better than the anti-TNF, although the significance here is not strong. When you look at a harder endpoint, remission, you can see superiority of the combination over either of the monotherapies. Of course, there's no placebo arm here to get a feeling for what the untreated benefit or the untreated outcome would be. And if I had to be 100% honest, I guess I would be slightly disappointed with a 36% remission rate with a combination of an anti-P19 and an anti-TNF in a group of patients with moderate to severely active ulcerative colitis. I guess the key take-home message is there didn't seem to be an adverse safety profile of having two drugs versus one, but of course, bear in mind that this is just the induction study, and we need to see the maintenance results to see whether both the efficacy increases, but also the safety profile remains flat.
Yeah, it's difficult, isn't it? Because you just don't know how bad these patients were.
Without a placebo, you don't know.
Right, and I take away from it equally that combo is better than monotherapy. And so it encourages me that this strategy of combining therapies is probably something that we should be exploring further.
I'm sure we should be exploring it further, but if you think of a cost perspective, the incremental benefit you get in terms of remission there, you're doubling the cost, well, not more than doubling, because of course neither of them are biosimilar.
Right. But the flip side of that, of course, is what you just said. Biosimilars are increasing in number. When small molecules come off patent, they're extremely cheap potentially. So anyway, a very quick summary slide here, and I'm just not going to go into this in detail because we're running short of time. Risankizumab, again, is also not too far away for Crohn's disease. We've seen the results of Advance and Motivate, they're the induction studies, and Fortify, the maintenance studies of risankizumab in Crohn's. Again, a really strong signal that P19 is an attractive mechanism of action in patients with Crohn's disease. We can see from these studies that the endoscopic outcomes are encouraging both in biologic naive and biologic failed patients, and indeed that disease location, as we've seen previously, matters. Colonic disease tending to respond better than purely ileal disease. But risankizumab not too far away, and again, I'm really looking forward to having access to that. But I'm going to flip over to the next study, which carries on the combo debate, doesn't it? So this is a trial called Explorer, which actually was started some time ago. It was a pretty advanced concept back then, I think, and it was I think it was just done in New York, if I'm right, just done at Mount Sinai. And in this study, they took patients and treated them with a combination of vedolizumab, adalimumab, and methotrexate altogether. And in fact, many of them were on steroids as well, if I remember rightly.
Yeah, they were.
Right, and this is in a biologic naive patient, newly diagnosed, that's diagnosed within the last 2 years, with moderate to severe Crohn's at moderate to high risk of complications. Let's not go into that too much. Of course, the difficulty with this is there was no control arm here. 55 patients, there we go, 30% of whom were on concomitant steroids as well. Then if you look at week 26, endoscopic remission was seen in about 35% of them, clinical remission in slightly over half of them. What does this tell us? Well, again, I think I'm going to draw the same conclusion that James drew from the Vegas study, and that is, even when you combine here 3 or even 4 mechanisms of action, what's important is you didn't see a whole lot of nasty side effects. And I think to me, cost clearly is important, as James has just highlighted. But of course, when you're combining treatments, probably the thing you're more worried about than anything is side effects. And so that's 2 studies there of combo therapy. And if you think back to Sonic as well, that's another study of combination therapy. And indeed Comet, you might not remember that one, methotrexate and infliximab, I think, with steroids at induction as well. That's several studies showing that at least in the short term, we can combine therapies safely and effectively.
So let's just have a look and see if there are questions. Yes, we do. Let me just have a look and see. Yeah, no, we've done that one. So, okay. Which drug should, this is Gareth Walker, which drug should you stop? Oh, I see. Sorry, no, I've got the question wrong. Which drug in UC and Crohn's disease are you more excited about, upadacitinib or filgotinib, Peter?
Well, I think the honest truth is there, I don't know yet. And you know, if you look at the data, the UPA data are really quite spectacular in ulcerative colitis. I think you can't really say anything until you've got it out there in clinical practice. And it's nice to know that we're going to have a JAK inhibitor in Crohn's disease as well.
I think it's really key to understand the fact that there seems to be a really strong dose response with the small molecules, and whereas I'm relatively comfortable that upadacitinib has explored its dose response, I'm not convinced that I think that filgotinib has explored its dose response.
Well, the top of its dose response, what you mean.
Response. And so it's entirely possible that in time we'll be using higher doses. Of course, bear in mind the fact that with its dose response issue, there's also a dose side effect issue. The higher the dose, the greater the side effects. And that's a striking difference from biologics, where the higher the dose, not necessarily the higher the side effects.
Nor, in fact, the better the response.
No. So the next question here is, with the SPARE and STOP IT, which is the UC stopping trials, having reported their results, should we no longer consider de-escalation of anti-TNFs in patients? Sorry, they're both Crohn's disease. And I think that's a really difficult question. Certainly, I mean, I think partly because of the COVID pandemic and partly because of the cost of the drugs reducing with biosimilars, I certainly don't now have a sort of policy that at the end of a year I need to be considering stopping drugs. I mean, I do discuss it with patients, but we can be absolutely clear to patients that if they stop their anti-TNF in Crohn's disease, they have a 50% chance of flaring. So, I mean, that's either a glass half full or a glass half empty, depending on your perspective. But I definitely don't think we need to be stopping therapy at the end of a year, Pete.
But there's another message, isn't there, from these studies? And that is about if your patient wants to try stopping, because it's not necessarily us driving that.
Absolutely.
It's often patients who want to stop. And, you know, and SPARE kind of says, if you keep a close eye on your patients and you stop and you restart, then that's okay.
Absolutely.
And, right, you know, we've got to listen to our patients, haven't we?
And I think that, yeah. So I think if you've been, I mean, of course, you have to bear in mind what it was about SPARE, those patients that stopped and recaptured, because they would have been in remission for, as you said, for a chunk of time.
Next question here. Do you routinely check anti-drug antibodies before re-challenging with anti-TNF?
That's a great question. And the answer is no, I don't routinely do it. Peter, what about you? And if I can ask, what about, do you detect, so if a patient's been off an anti-TNF for a period of time, do you still detect anti-drug antibodies?
Right, so they can disappear.
Yeah,
they can disappear. There was a really nice study back in the days when we used to retreat with infliximab because we had no other options. So there's a lovely study from Leuven. I can't remember who the first author was, but not surprising, I think Severine was at the end, in which they looked at this question exactly. And of course, when you did detect anti-drug antibodies, then your chance of failure was higher. But you know, the reality is they can disappear. I guess nowadays, is there any harm in doing it? No. If they had anti-drug antibodies, would that change what I did? Yes. because we have so many other options available.
Yeah, but you don't do it, do you? No.
But I don't.
No,
Exactly.
Another question here from Anjan Dar. It's a great question, Anjan. Can we escalate sub-Q infliximab or vedolizumab to weekly, or as I presented in the sub-Q infliximab trial, to 240 every other week? I mean, the simple answer to that is neither of those are licensed doses. So the escalated dose, the 240 every other week infliximab, is not a currently licensed dose. So can you? Well, of course you can. Would you be able to? Currently, within our commissions, we would not be able to.
But would you be prepared to do it? Absolutely.
Would I be prepared to do it? Definitively.
Not least because, am I worried about increasing side effects from increasing doses? Absolutely not.
So a great question here from Ahmed Kadir, one of our pediatric colleagues at the London. Do we routinely do infliximab levels when in sub-Q infliximab? Yeah, we do, but I'm not sure I know how to interpret them, is the simple answer. They're undoubtedly higher than they are on the IV dose.
Right, I love this. It's a great study. There's lots of drugs out there. It's a little bit confusing. Should there be some sort of rationalization so that options are whittled down based on head-to-head studies? Do we need so many drugs? Of course we need so many drugs. It's fantastic having lots of different drugs. I'm teasing. I think, to be honest, this takes me back to our last biologics meeting on Friday. And we sat there and we talked about a whole cohort of patients who had gone through the options and they didn't have anything left. So yes, I think we do need different drugs, but I think there's a subtext to this, isn't there? To my mind anyway, and that is, have any of the drugs come through and suddenly blown everything else out of the water? And the answer to that, to me, is no. Not yet. I don't think it's going to happen, James. I don't.
I'm very impressed by the Uber Crohn's.
Yeah. But still, I still think it's not going to be the answer. And I think that's why we need to think about other answers. And I think that is why combo therapy is important. And that's actually what this next question is about, combo therapy. Why was golimumab selected as the anti-TNF of choice in the Vega trial? Really simple. I think it's because it's Janssen's drug.
Yeah, and they're both Janssen drugs, so it's much easier for them to use two in-house drugs rather than buy one in. But we've had a great amount of questions. I really, really want to thank you all for being so interactive. This is probably the most questions we've ever had at CornerStones. And we're gonna end. We've got one more question to answer, and then actually we're going to end here because the rest of the slides, the disease activity monitoring, the ultrasound, they're all going to be covered in our deep dive, which is on August the 11th. And the last question, if you were to use in Explorer that combination of therapies, would you give antibiotic prophylaxis? Well, I don't think they did in the study, but if I had someone on steroids, an immune modulator, and an anti-TNF, and in this case also vedolizumab, I would be using Septrin. Our current belief is if we've got people on 3 immune suppressing drugs, so that's like steroids, infliximab, azathioprine, they get Septrin. And there was a lovely study, we've not got it here in our set, but there was a lovely study from Korea looking at the risk of opportunistic infections, particularly PCP, in patients dependent on their biologic and immunosuppressive exposure, showing exactly what's been shown before in European data, which is triple immune suppression is the biggest increased risk factor for developing opportunistic infections. So the simple answer, Catherine, is yes. We're going to finish here. Thanks so much.
Cheerio. See you.